A special presentation here from Professor John Sanders, a medical educator, and I would like to thank you for your visit here. It's very important for us. It's a great honor to have you here and to have the opportunity to see, to watch your presentation. Thank you very much, Mr. Professor John.
Well, thank you very much. I mean, it's a great honour to be here for a start, so thank you very much. It's my first time in Brazil, and not the first time in South America, but of all the countries that I've been to in South America, I think this is probably one of the most, it's the friendliest I've been. So thank you very much for the welcome, and it's a great honour to be here. So who am I? Because who am I to come to you and to give you a talk? So I started life, like most people, I went to medical school. I went to the University of Sheffield, which is a very traditional medical school. So it was very much lectures from professors, and we were doing dissections. But going back before that, at my school, I had two teachers that stand out in my mind. One was the physics teacher. The physics teacher had a PhD. He'd trained at Imperial, and he was really, really passionate about physics. And what he did, his teaching, everything was written on the blackboard. We didn't have a photocopier then, in the 1960s, but he had a machine which he used to do, and every single lecture was a whole pile of handouts. Then I had a biology teacher who was absolutely passionate about biology, and in retrospect, it was similar to problem-based learning, because at the beginning of each week, we would talk about topics. We had a very good library. This was the days before the internet. We had a very good library in the department, and we also had Scientific American and the New Scientist, and he was expecting us to read that And he would talk about it, talk about what we were reading, direct us to where we did that. And if you look at the grades I got, physics, I got the lowest pass grade. And biology, I got the highest possible grade. And when I went to medical school, it hit me that it was just like being the physics teacher. And I thought, if I continue to do medicine like this, I will not get through. So I actually started to do the equivalent of the biology teacher. And I went through medical school, and I got, and it sounds arrogant, but I got the prize for the top student and the gold medal. And I thought, this is what education is about. And I then trained in hospital medicine using the same and got through my internal medicine exams. And then I had thought, you know, what do I want to do as a career? I enjoyed teaching students, but my next job was to do a pharmacology research job on lactic acidosis. And I thought, do I really want to do that for the rest of my life? And I changed career because I could then, and I became a family physician. And the training of a family physician in the UK, at that time was not compulsory, but what hit me about it was that it was about much more about personal development and awareness, and we've just been talking about this, much more about ourselves and our relationship with patients. And I got heavily interested in palliative medicine, so I had to start thinking about that. I started teaching, and I became passionate about it. So I ended up doing a degree in adult education. And that was like going into a sweet shop with lots of different chocolates and sweets, because I had never read about educational philosophy. I'd never read about a lot of these ideas in education: self-directed learning, experiential learning, transformative learning. And I was just mesmerized by it. So I ended up doing a master's, and I did that with the professor of education. And suddenly a job appeared at Manchester University, because I was heavily involved with training family physicians. And when I moved to, it was for 1 day a week, and Manchester was introducing problem-based learning. Overnight, the whole of the medical school course at the University of Manchester in the late 1990s was changing to be problem-based learning. And every single day, students were having to find their own learning. And to be quite truthful, after a couple of years, it started to degenerate. It went back to the teaching much more didactically. It didn't really work. And again, it was because of the staff training. And I started to get involved with that. And then a public health course, a new professor of public health came, and I was introduced to him. And he had had a vision of doing the first UK online masters in public health. So I got heavily involved with developing that. Now, developing this was absolutely fantastic, because we had to have 12 modules ready in a year. 12 different public health specialists. How were we going to do this? How were we going to write all the content in a year? So we didn't. What we did was to each week there was a list of learning objectives. We directed students to resources. Some were online, some were related to books. So during that time, the students were expected to do that. At the end of each week, the students did a small quiz to check their knowledge. They got some feedback. These were much more conceptual. And the students started to thrive on that. So you can see where I'm coming from now. I became increasingly interested in having students being much more self-directed rather than traditional. And when you've seen it yourself and believe that you can learn like that and do it effectively, you see others doing that, you begin to have a philosophy. By that time, I'd done a doctorate, and it was on online networks in public health and why they actually all failed. But I learnt a lot about how people learn. And I was doing 50% as a doctor and 50% working for the university. And suddenly a job appeared at the University of Leeds, which wasn't far away, and I could continue being a doctor 1 day a week. So I moved there, and I became associate professor in medical education, and I worked with a colleague, some of you may know because she was the president of AME, called Trudy Roberts. And there, I was responsible for developing the personal and professional development program, which included communications, ethics, and reflection and professionalism strand of it. And I was also the associate director for student support, and I became heavily interested on how individuals learn. And I was fortunate to be able to go to the States on a travelling scholarship. And one of them, I met a scholar of a person called John Dewey, who was a great American educationalist. And I became passionately interested in that, because again, it was about developing individuals. Of course you need knowledge, skills, but you also need the attitudes, and you want people to become a future global citizen as well as a doctor. So it was about personal growth and development, and I became really interested in that. And we were able to introduce that into the curriculum. What then happened is that I was there for 10 years, and I got to the age of retirement. In England, you can retire as a doctor at 60 on a pension, and so full pension. So if I'd continued to work any longer, it would have affected my tax and things like that. So I decided to retire from the University of Sheffield, University of Leeds. But one of my colleagues moved to Sheffield as the dean, and I moved to Sheffield as Professor of Medical Education there. And then the times were changing, political changes in the UK, a lot of funding for the big universities started to disappear, and I don't know, there was a lot of unhappiness going on. I was just at that moment, and I thought, I don't really, and I was having to commute 40 miles each day when I went, and I thought, I'm not so sure if I want to stay here. And I was talking to a colleague, and he said, why don't you come and join me at Edge Hill University, which is a small university halfway between Manchester and Liverpool. And the background there was that this was basically a teacher training college in the past, and a big nursing training, plus liberal arts, history, sociology. Small university, and Dario and Diego have been there. And isn't that beautiful, isn't it? Now, I had a colleague who was doing a lot of research and evaluation for the health authority. And that's why I started there doing part-time work, a couple of days a week. After about 6 months, the government announced that they wanted to expand the number of medical schools in the UK. So the dean of the health faculty, which is nursing, and the vice-chancellor of the university, the boss, said, we want to apply for this. They said to me, are you up for it, John? And I said, yes. So myself, the dean of the faculty, and another colleague who was in public health, who now acts as the manager for the course, we sat down and we thought, what are we going to do? Are we going to take in another medical school's curriculum, or are we going to write our own? So we wrote our own. It's hard work, but that's what I'm going to share with you, because I think a lot of these issues that we had to go through are highly relevant to other universities that are thinking of changing or developing their curriculum. So that's what I was going to talk about. Is that okay? I haven't bored you yet. Am I pressing the wrong one? There. So, we have had a very nice building which surrounds a beautiful lake. That's on the left there. And that was the faculty building. So we had no facilities for a medical school. We just had lecture rooms, nothing else. And then there was that building on the right there, which had been used for teaching. So what we did, the university agreed that that building on the right is actually the medical school. So it was completely cleared out, all the rooms. So we decided, well, how are we going to teach anatomy? We haven't got any anatomy people here at the university. Are we going to do dissection? No. So what we did, we had a room like this in part of this building, and we got 2 Anatomage tables. I'm not sure if you've seen them, but essentially it's a computer screen, the same size as a human being, and it looks like a cadaver, but what you can do with it is you press a button and the skin comes off. You press another button and you can take a muscle off, and you can move it around 360 degrees. You can press another button and you've got a cross section. If you press a particular point, you can get the histology coming up. So that's what we started with. And because we had no real contacts with the hospitals. So we started talking to the hospital providers, and the radiology people said, we want to develop a training centre for training our radiologists. So a room in there became that centre. So the idea in the UK was that if you want to decide to become a radiologist, you have to, rather than going straight into the job, for 3 months, you work in a smaller group of doctors so that they feel fully confident and competent on interpreting the images before they ever go into a clinical situation. So those doctors have now started to teach our medical students anatomy. And they show them the ultrasound, and we've got the ultrasound trainers, but also cross-sectional radiology, such as CT scans and MRI scans. So the anatomy is very rich. We also decided that we wanted to build simulation. So basically, we've built simulation suites in there for a ward. We've got patients' homes. We've got consultation rooms, just like in primary care. We've even got somebody's house, which has got a bed inside it, toilets, kitchen, so that we can do that. So we made that decision. This is what we wanted. We've got an obstetric delivery suite. So that has all been developed. So what we then thought, we're going to have to start this building program, because we wanted to start a medical school within about 2 years. If we were going to do that, we needed the physical resources, and these take time to convert. So that's why I've started with that. We had to get the basic facilities. So once we started that process, we had to go through the next bit of thinking about what is a curriculum. First of all, it has to have aims. It has to have content. It has to have the methods of delivering that content. And I think assessment is an absolutely key component. And all that occurs within the context. And in the UK, this context is the General Medical Council. Just like you have in Brazil, any other country in the world, the government also dictates what you should have on the course. So that was a challenge. But within the UK, and perhaps in Brazil, and I think in most areas of the world, this is quite rigid, but allows each medical school to develop it in a slightly different way, as long as it fits in with the overall plan. So, the aims. The content we call the syllabus in English, rather than the curriculum. The curriculum is the aims, the methods, and the assessment, because literally a curriculum means a road or a racetrack. So it's more of a map, whereas the content, the syllabus, is what we're going to be teaching. And that is dictated, on the whole, by the government through the General Medical Council. And you've got it, and it's, by the end of training, all doctors have to do this. And that some of it is knowledge-based, some of it is skills-based. Now, we're slightly different in the UK because our doctors, at the time when they qualify from medical school, they go into 2 years of what we call protected training. And I understand in Brazil it is different, that they have to be ready for practice. But, we have a similar challenge, but our course is 5 years. So we don't do a longer course. What we also wanted is to be very clear about what our mission was and what our vision was, and I'll come back to that. This is something that we believed in, and we call it putting your colours in front of the mast, nailing your colours on the mast. It's something which this is what we believed in. So we could communicate this to staff, students, the General Medical Council, and the public. So we developed a mission statement and a vision statement, and I'll show you what we developed. And then what we really were keen on is to ensure that we were focusing on the doctor of the future, not the doctor of today. So we had to think, we're preparing a future generation of doctors for professional life. And that is a vision as well. And coming to the methods, we also decided what type of learner do we want. And I think this is absolutely crucial. For me, a learner is an individual who first of all enjoys learning. They're learning because they want to learn. They're stimulated, they become self-directed. Of course, they may prefer to be given information, but is that actually helping them? So what type of learner do we want? Do we want somebody who is a rounded person, who can think about wider societal issues? Do we want them to be socially aware? Do we want them to be balanced? We know, unfortunately, I don't know what the position is in Brazil, but the suicide rate amongst doctors is actually high. It's the highest of all professions. So we want to consider their future well-being. How can we maintain that? So all these things are part of our mission statement, part of our vision. We believe that students should actively learn, and we wanted it to be holistic, professional, clinical, and personal. And we also believed in assessments. So we consider that there are assessments of learning. These are summative assessments. We felt that they shouldn't be particularly often, because students, as we know, read everything the night before. But what we do are lots of assessments for learning. In fact, we have an assessment every week, and I'll explain why we do that. An assessment is to help the students to learn, and it helps us as teachers to know whether the students are in fact taking on board the information that we are presenting and discussing. And for us, assessment, what do I know? Do I need to find out anything else to answer it? Where am I in this learning process? A learner, we believe that at any moment in time, a learner should know and be aware whether they have got the appropriate level of knowledge and skills, and we should be aware of that as teachers as well. So it's a bit of a challenge. So for us, it's a continuous process. And what we want to be able to measure is not just knowledge, we want to be able to measure skills, but importantly, their values and behaviours. We're very keen on picking up professionalism, professional conduct. And we have multiple methods of it. And that's getting that balance between validity and reliability. Because the most valid assessments are not necessarily the most reliable. These are judgments. Equally so, the most reliable measures are not always particularly valid. So, for example, using multiple choice quizzes to measure skills is not ideal. We need to be watching skills, seeing skills. So we need to think all that through. So when we started to put everything together, that was our mission statement and our vision. MBCHB is what we don't, in England, an MD is a higher degree like a PhD in England. You can only do an MD in England if you are a medical doctor. It's equivalent to a PhD, and you get 6 months less to complete your PhD. I know the equivalent. So you can do the program, same as a PhD, it's exactly the same standard, but you have a shorter period of time where you can complete it. And the idea is that you've already got some extra skills in research by taking it. It's historical. It's because medical schools started doing that. So it's an unusual type of aspect. So we call it MBCHB, which is Latin for Bachelor of Medicine and Bachelor of Surgery. So that's what we have in England. And that's what the MBCHB says. So that's what we sat down, and that's what we presented to the General Medical Council, to the public, to the hospitals, where we had to get, because we didn't have the hospital contacts, we had to get surrounding hospitals involved, attracting staff to come and work for us, attracting students to come to us. That's what we made public. And that was a very clear, deliberate vision. It was our vision as a very small group, but what we then started to share with the university and colleagues who were interested in starting to work with us to develop a new medical school. And ours was that it will develop future doctors. The focus was on future doctors, giving them the skills for the future. And that was a commitment to improving the health of the community. There are other medical schools that have got very long traditions. Not very far from us, we've got Manchester and we've got Liverpool. They've got long traditions of developing the clinical specialties, surgery, neurosurgery, obstetrics. But for our students, we haven't got the hospitals that are these centres of teaching excellence. We've got hospitals which are providing secondary level care, not tertiary level care, but also the community. So our focus was very much about the community. And that was our aims of the programme. And as you can see, we put there lifelong learners committed to their own professional development and well-being. And that was a key aspect. And the GMC is the General Medical Council, and that was the outcomes. So we then started with that. And then what we did was to develop what we called a curriculum philosophy. This is what the philosophy of our teaching, the whole process of our aims, our methods, and our assessments, we came up with this. Number one, we felt that students should have early clinical engagement. They should know this is the job you're going to be doing in 5 years' time. From day one, when they come through medical school, they are going to be future doctors. Unless they make a horrendous mistake in medical school, do something totally unethical, 99% of students graduate from after medical school. I don't know what the number is for your medical school, but very few students actually fail and get thrown out of medical school. So, the moment when they walk through, they want to do medicine, you're going to be a future doctor. So you need to think, you need to act, and you need to start developing those professional behaviours. And you need to know the job that you're going to be doing in 5 years' time and for the rest of your life. So we believed that from the moment they enter medical school, they should be aware of what being a doctor is. So we wanted early clinical engagement. We also wanted to enable students to have much more longer-term clinical engagements, because that, in the early years, because they haven't got clinical knowledge, was actually working in the community for a whole year. And I'll go through that a little bit later. So we have a service learning opportunity during the second year of the course, where they work with voluntary organisations so that they can begin to see the social determinants, because some of the students have never worked in organisations like that. They work in pairs, but it's not just going there to do the job, it's they reflect on that, what they're learning about the community, what they're learning about themselves, the challenges, and it's integrated into the course. And for the clinical aspects, the traditional models are about 3 months surgery, 3 months medicine, 3 months obstetrics. Now we're still going to continue doing that in our clinical years, but what we've decided, we want the students to be attached to the same hospital, so that they can start becoming integrated in that hospital. Because many of the medical schools in the UK, those 3-month slots are in different hospitals. And one of the difficulties with that is then the students don't see all the interactions between the departments. They don't come to the staff meetings because they don't understand the patient journey, because the patient might move across specialties. So our vision for the clinical years was to work in the same hospital as much as we can. And our local hospitals have been really enthusiastic about that. And the other aspect, the staff can get to know the students as well, and the students can get to know the staff. And I think that's absolutely crucial, because then they've got good role models. Students can see and understand the stress that doctors have and how the doctors deal with it. And there's all that social talk as well that goes on. And they become part of that hospital, really. And some of the work that we've done when I was in Sheffield was about the sense of belongingness. Medical students feel that they want to feel this sense that they belong. They're not just coming along to a clinic. They're actually part of that healthcare by the hospital. So that's what we started to do. We also wanted to be able to integrate theory and practice. So if you're learning, when I was a student in Sheffield, so Hans Krebs, remember the Krebs cycle? So Hans Krebs had worked at Sheffield. So the biochemistry department, we had to learn the Krebs cycle absolutely backwards. And we had a multiple choice paper on the Krebs cycle, all the various stages of it. One of my best friends failed it, the paper. If he had failed the resit, he would have been thrown out of medical school. That guy has just retired, Jeff, and he was a renowned middle ear surgeon at the National ENT Hospital in London, and an authority on stapedectomy. Has he ever used the Krebs cycle in his career? No. We never knew why we were learning the Krebs cycle. I'd trained in hospital medicine and general practice. I've never used the Krebs cycle at that level. How many, phosphorylation. I had no idea why I was learning it as a student. I was learning it like a parrot. So anything our students learn, this is why you need to know it. So what we have is a mixture of case-based learning and team-based learning, and I'll go through that of what we did. We decided not to go down problem-based learning. Okay. And I think there's a huge temptation that it's basically go and find it out yourself. That's how the students perceive it often. It's highly intensive. You need to have experienced tutors, and many universities that have adopted problem-based learning, it becomes more of a hybrid. The whole course doesn't go around it. And some tutors find it incredibly difficult to work and teach in that approach. So we didn't go down that. I'll tell you what we did do. We wanted people to feel prepared for practice. That was number one. We wanted people to become lifelong learners and to be able to reflect on what am I doing, why am I doing it this way, do I need to do it differently? We wanted people to be an advocate for health and to understand that they have a social responsibility to local communities. So we encourage students, particularly in the second year, to get engaged with local communities, this longitudinal attachment. And we wanted students to work collaboratively together. Medicine, students say they want to work together, but actually they're highly competitive. And we wanted to try and make sure that the students actually were beginning to share information together so that they are learning together. And we also wanted them to be able to work interdisciplinary with other professionals well. And one of the advantages of Edge Hill is that, because it's a completely new medical school, is that there were existing departments, particularly a big nutrition department, and the Department of Nutrition has really engaged with our students. I have to say that we haven't been as successful with the nurses. It's not because they don't want to, it's just that their curriculum is quite rigid because it's dictated by their organisation, and it restricts it. And it's been a bit of a challenge. But with nutrition, it's been much easier. And in fact, we have kitchens because part of it is making food, so our students do that. The nutrition is about how people prepare food, what the social determinants of diet, the impact of a poor diet. So our students can learn with these students in nutrition. So that's been really, really useful. Been particularly helpful. And we also have what we call a spiral curriculum, and you'll see that we go through all the systems in the first year, and then it's repeated again in the second year, but with a different emphasis. Now, this is our typical first and second year. So this is year one. And I felt that when you come to medical school, what's the first thing that happens? You turn up to medical school, the dean says hello to you, and then you have your next lecture, which is physiology. And they say, welcome, this is your book list. The next lecture, the next session is the anatomy people. And they say to you, this is what our course is. This is our recommended book list. And they just go through all of that. Is that right? Is that typical? Is that typical here? It's certainly typical in my experience. Well, we decided that's not the best way to go about it. You want the students to be able to work together. You want the students to be able to become self-directed in their learning. You want them to be thinking about what is this job of being a doctor? What do they actually do? What does a nurse do? So for the first 5 weeks, when they come to our course, they don't get the book lists. What they get is sessions on what is it about being a doctor? What does professionalism mean as a doctor? What are the implications for you as a student? How are you going to use social media? How can you make sense of information that you're reading? What do you think about Wikipedia? Is it a good source of information? What's the limitations of it? We talk about the importance of evidence-based practice. Why is it important? We get doctors to come in to talk about this is the job I do. We get people talking about this is what a nurse does. Because some people have never seen it. All they've ever seen are television programs. We talk about what do they see themselves doing in 5 years, 10 years' time. We get them to start talking. We cover some of the basic structures again, as a recap. Cellular structure, basic biochemistry if they've done something, before they start going through the next systems. Now, all the systems are based on 2-week cycles. So basically, endocrine has a 2-week cycle, which is 4 weeks. And I'll show you what the cycle is. Then we move on to neuroscience. Then they have a break for Christmas. Then they do the cardiovascular system. And then they do what's called a formative assessment. This is what your final assessment's going to be like, but you don't have to pass it. But it gives you an idea what to expect. Because by that time, students, often want a reality check. And this is quite, it's a multiple choice paper, but what we also do is the students have to keep a reflective diary. It's not marked, but it's compulsory that they do that. So it's a good check. Are they completing it? How are they completing it? Also, they've done some skills. In the first year, it's quite simple clinical skills, like urine dipsticks, taking a pulse. It's quite simplistic. So at that level, they have an OSCE exam. So they begin to see what it's like. And they discussed about how do you prepare for it. Was it a surprise that you didn't do very well because it was all last minute? Or you're actually doing no work, you're spending your time, socialising too much? It's a reality check for those students. And then they're able to have some support and extra help if they need it. And then they go through all these cycles again and they have the end of the year examination. Now the second year is exactly the same, except we don't have a fundamentals block, but they have some attachments. They have basically a 2-week attachment in primary care and a 2-week attachment in hospital medicine, general hospital medicine. And they have the same exam structure and they go through those subjects again in the same order. In the first year, I'll show you, the focus is on normal structure and function, and the second year it's on the pathology. So that's the spiral curriculum. They're going through it again because you need to understand structure and function before pathology. So it starts to link in. Now, this was my vision of providing education. And the first 2 years, the course runs like this. The clinical years run a bit more like the traditional teaching. So, they're going to the hospitals, they do ward rounds, but with an underlying philosophy. So, you're learning, say, endocrine. At the top is week 1. So, at the beginning of the block, or the second week of the block, the second 2 weeks, beginning either at the beginning, it's 2 2-week blocks. So basically, this is one of the 2-week blocks. So in the first week of a 2-week block, what they're presented with, in small groups, we work in small groups of 12, is a projector like this, and we give them a clinical case. Now, the clinical case is very simple. So, for example, if it's endocrine, what do we need to, what we thought, well, what are the key things you need to know? The key endocrine systems. So we thought diabetes is pretty important, and we thought thyroid disease is pretty important. So one of the cases is somebody, a 58-year-old man who's obese presents with being thirsty all the time and passing urine all the time. And you do a dipstick and it shows that he's got some sugar in it. That's what it says. This man is married. He works as a lorry driver. And his wife has recently had breast cancer. So we give them a little bit of information. And then what we say is that this is a problem you're going to be faced with in 5 years' time. So if you're going to deal with this, what do you think some of these problems that you're going to have to deal with are? So they say, well, it's not completely new to them. So they say, well, yeah, I think he could be a diabetic. Okay, so why do you think he's been thirsty then? And you get them to start talking about it. And then you start talking about, why do you think it's coming out, the sugar? So what if he was going to have treatment, what would the treatment be doing? Well, he'd have tablets, he might have insulin. So what's insulin? How's that produced? Where's it produced from? So you start getting to be thinking about it. So you're saying to them, so you need to know something about the function of the pancreas. You need to be thinking about the function. Is obesity related to it? You then start talking about the fact that if he does become diabetic, which he is, does that have any implications if he's a lorry driver? Might have. What sort of implications? Okay. So we get to start thinking about that. And does it really matter that his wife's just been diagnosed as having breast cancer? Yeah, it does. And you get them to start talking about that. It's upsetting the family dynamics. And then what we say is, well, over these 2 weeks, this is what we're going to be focusing on. This is what we expect you to know by the end of the 2 weeks. Now, this is where we have a curriculum map. So basically, we expect them to understand, for example, the ethical aspects of reporting information to the, in England, the patient, if a patient is a lorry driver and they're going to insulin, say, the responsibility is technically the patient's responsibility to do that. However, if the patient doesn't do that, you have the right as a doctor, providing you warn them first, to report them to the licensing authority for driving. So that's an ethical decision. So it's about ethics, patient autonomy. So that's an area so that's an area of ethics. There's something about understanding the impact of relationships and family dynamics and nutrition and the impact of illness on families. There's something about the structure and function of the pancreas. So basically, it's the traditional aims and objectives, but it's holistic. So it's covering aspects which are ethical. You might have something communication. How do you break bad news, say, to him? So what we have are those objectives. Now, during that week, there are activities which we call learning experiences. There might be small groups. There might be didactic lectures. There might be a visit somewhere. There may be somebody comes in, a patient, talking about what it was like being told. They might do a breaking bad news scenario. There might be a small group discussion on the ethical principles. There might be a didactic lecture on the biochemistry. You've got the anatomy lab about the structure of the pancreas and the histology. Somebody else might talk about insulin. So, where does it come from? How's it produced? Different types of diabetes they might talk about. They might be talking about diet, so they do nutrition. So all those aspects, they have different experiences during the week. Then at the end of the week, the group come back together, because some of those sessions might be a whole group, whole year. Some of them might be in small sessions, and they're repeated twice. And there might be a visit to a diabetic clinic, just to see what goes on in a diabetic clinic. So what we try to do is to enable the students to have a range of different experiences. Now, the good thing about that is that the teachers can teach it on how they want to teach it. So we're not rigid that this has to be problem-based learning, this has to be a lecture, this has to be experiential. It's down to the individual tutor of how they want to teach it. So the tutors have a relatively large degree of autonomy, because we do have clinicians coming in as well. At the end of the week, there is a small group discussion about, well, what have you learnt as a whole group this week about this management? So you get a discussion. Is there anything surprised you? Is there anything difficult? So they're looking at some of the aspects, particularly the ethical, about breaking bad news, about their experiences that they've seen. The tutor also looks at, so how have you all been working as a group in the sessions? Have you met up? Have you been sharing your learning? Yeah, we got together and we looked at. So where did you look at information? So there's a bit of discussion about that. And then, what the individual development is about a personal reflection and what they think about it. Now, the case begins on the Monday. Some of the Monday afternoon will be the mosaic sessions. That's done on Friday morning. And then Friday afternoon, at the beginning of the first week, we've started to introduce a clinician to come to talk about their experience of managing a patient with diabetes. They're also, at the end of that day, the Friday, they are given a small quiz to do based on the core concepts that they should have covered that week. The following Monday, in the group, they discuss the answers to the quiz. So they say, so what did so-and-so do? How did people answer this question? Met with the structure of the islets of Langerhans or something. What do the particular cells do? I can't remember it now. But it's something which may be anatomy, something about physiology, something about glucose homeostasis. So these are core conceptual questions. They are factual, but it's about if you got it wrong, what is difficult for students to understand. So we say to the tutors, what do you think is essential for that student to know? And what do you think students struggle with? So most of us can think of conceptual type of questions rather than just pure factual. And we've tried to help the tutors to think this through. And I think on the whole we've been successful. So they have usually about 5 or 6 conceptual questions which across the various domains. And the students discuss what answer they did, they discuss what they've done, what they thought individually, and then you get other people to start discussing it in the group. And it's an opportunity for the tutor who's managing the group to clarify whether they've got it right or not. They have an aid memoir The students then have another range of learning experiences for that week. And at the end of it, they're reviewed again of how they've learnt that. And that's the system we work on. And I think some of the advantages is that it creates some degree of self-directed learning. The students know where they are with their learning, with the assessment. We know where they're learning. There's an opportunity to pick up students if they've got an issue. Tutors can teach how they want to teach. The only extra work that we've had are to have tutors who meet on a Monday morning and a Friday morning each week. And we have started to employ family physicians for those 2 sessions. Some of them have been paid. Some of them, we have a system in England where the doctors are state employed, but they work independently, so that they can alter their hours, and they can take in an extra member of staff. So if they're not there, they can employ somebody. But also, 50% of the workforce is female, particularly. They would like, they don't want to work full time. So there are opportunities to work part-time in practices and balance it. We call it a portfolio career. But there's also doctors who are employed, particularly in areas where doctors don't want to work. They're employed by the local health authority. And what's happened there, they've given their staff, because it's like a goodwill gesture. So we've been quite lucky, because they're hoping that our students will go back into their area to work. So we have a different model, really. So, and they've been trained and they're aware of how to run these groups, and they have some clinical knowledge. We found that so far the students love it. They found it really, really interesting. So year 1, the focus is on understanding the person, the community. It's an emphasis on the life sciences, but also the social sciences. And each week, the students see what we call good examples of healthcare, particularly multi-agency. So during the first year, they go out in pairs and they go to a whole range of organisations. And they're not the same each week for all the students, but over the course of a year, they would have gone through similar experiences. So, for example, they might go to they'll see a diabetic clinic in action. They might see a GP in action. They may see a pharmacist in action. So the idea is that they are expected not just to turn up and it's irrelevant to what they're learning. When they come back, it's discussed where they've been and how that links to the case of the week. So, for example, if it was diabetes, 2 of the group of the 12 might have gone to a pharmacist, 2 might have gone to a GP surgery, 2 might have gone to a hospital clinic, 2 might have gone to we have things called food banks for poor people, where supermarkets have produce which is going to be thrown away because it's getting towards its best buy date, and they give it to a food bank so poor people can go to it and get the food for nothing. So they might go to a food bank. So at the end of the week, it's an area to discuss. So has anybody, where have people been this week? Oh, well, I went to a food bank. So looking at diabetes, what was important about that? Well, a lot of the food was junk food. So does that impact on people developing diabetes and obesity? Yeah. So, could you see how that? Why do you think people are getting that junk food? Was there any discussions? Well, yeah, these people didn't have any cooking facilities, so they wanted food which was already pre-prepared. So, it gets them to be thinking, oh, well, I went to the pharmacist. What did you see there? Well, the pharmacist was giving patients information. And what was he talking about? with diabetes. They might go to a chiropodist, podiatrist, some of the students. So they talk about managing diabetic feet. So it's quite a rich learning experience. In the second year, the focus is more on pathology, and they do have these times when they spend a longer period attached to a general practice and to a hospital, but they also have this voluntary service commitment with a local organisation, an NGO. And again, the students at the end of the year, they present it as a poster. Just before I came here, 6 weeks beforehand, we've started an annual meeting where we invite the people in hospitals and general practice who teach our students to come into the university and the local organisations. So we talk about what developments we're doing on the course. Is there anything that they can see develop in the course? The students are there as well. And the students had a room like this with posters that they'd had to create and stood next to and talked about them, about their experiences working in these organisations. Which organisation was I attached to? What did I do? What have I learnt from it? Both about it myself and also my role as a doctor. So the types of assessments the students are getting in year 1 and year 2, all students will have some knowledge-based test, they will have some skills-based test, an OSCE type test. They will also have to keep a portfolio, which is a reflection. I don't believe that reflections should be marked with a grid. You either reflect or you don't reflect, so they have to be reflective and not descriptive, and they have to complete it. And this is online, so all these community experiences is what happened, what surprised me, why did it surprise me, what are the implications for me as a person, but also for my role as a future doctor. And students are expected to have written something in that sort of format, to be thinking through that. And they do have opportunities to meet a tutor, these GPs who run those groups, to do that. If they don't do it, it's considered to be unprofessional behaviour. It's not professional behaviour if they do not complete it. And they're told, if you do not complete it, you will not progress to another year of the course. It's as simple as that. All the students have completed it. They've all enjoyed it. And all of them, they've gone to a whole range of organisations. We've got, women's support groups, health groups, community farms, allotment groups, all sorts of things. They're all related to health in some shape or form. And it's just incredible how the students have engaged with it. They've loved it, the organisations have loved it, and the students, you can see, they're getting this much wider understanding of what the job's about. And if you want to, essentially, going through this curriculum development, it's about designing it. You've got to believe in it. And if you're at the top, making the decisions, you've got to believe that this is the right thing. I believe this is what a good medical course should be like, because I've designed it that way. It's arrogant, but I've based it on experience, I've based it on best evidence, but adapted it to the needs of our medical school in that context, with the resources we've got, and recognising our tutors, recognising the communities, recognising that we don't have huge teaching hospitals with with the top neurosurgeons, the top gynecologists. We haven't got access to those. We've got hospitals of doctors who are passionate about teaching and are damn good clinicians, really good clinicians, and they want to get that passion over and they enjoy it. So, we've got them involved with the teaching. And they're bringing that in. So we believe that this design is appropriate. But we've also got to develop it in discussion with these doctors to make sure we can then implement it. And a lot of this is about change management. It's about faculty development for the teachers. But also it's about getting students involved throughout so that they have a say. And we're really keen on getting student information. And it's very easy to get students whinging what we're not doing well, but we want to know also what we are doing well. Because the way of dealing with the things that we're not doing very well is to do often replicating what we are actually doing well to those areas. And we've tried to get the students involved as much as we can. We've said, we want the best learning experience for you on this course. Some of the challenges, which I think come from the literature, is repeatedly in the UK, junior doctors say that they do not feel that they are prepared for practice. Even though they've got a degree, the day they walk out onto the ward, as a doctor, they don't feel prepared for practice. So, what do we do? Well, number one, we've decided that they need to have the opportunity to make mistakes, and to make mistakes in the context of simulation. And fortunately, we're able to replicate some of those scenarios. We've got clinical scenarios which are face-to-face, so they can practice breaking bad news in a surrounding which is somebody's home or in a consulting room. We can simulate ill patients. We've got all these, like you have here, I'm sure you know these fancy mannequins that cry and sort of move around and breathe and things like that. We have simulated patients who act. But we've also got a ward setting so that you can replicate a whole ward. And you can have a disaster happening in the ward. We haven't introduced this yet because we haven't got this far along the course. We're now in our going into the fourth year. We haven't been able to do it because it's the fourth year. But what we've planned to do is to essentially have a whole day on a ward with the medicine round, going round with the nurses, seeing the patients. So we're going to replicate that system as well. Obstetrics, there's the opportunity. Believe it or not, medical students in England do not have to deliver a baby. They don't have to deliver a baby. They have to have seen a baby being delivered. They have to know how to deal with the complications if something happens, how to resuscitate a baby, how to deal with a lady if she's bleeding. But an undergraduate is not expected to be able to actually manage the delivery. Now, whether that's correct or not is felt to be postgraduate. That was the decision. But we're going to get them prepared because we've got the birthing simulation. So our students will actually do it in that situation. I'm not saying it's right or wrong. I mean, that's a General Medical Council decision that they don't actually have to be able to deliver a baby. When I was a student, you had to be involved with the actual delivery. I think we had to deliver six babies. Nowadays, you just have to see it being done. Partly because we also have midwives in the UK who do the deliveries. So simulation is one, and the other one is teaching for transfer. Is that anything that we teach, we always try and explain to them why you are learning this. This is why you need to know this, because in 5 years' time, this is what you'll be doing. So we try and constantly do that and explain why you're learning it. The other thing is that when we do any teaching, we try and move a scenario on. So things like, well, okay, this is how you manage it, this is what it could be. What happens if it was a 58-year-old man and not a 22-year-old man? Would that be different? Would it be different if it was a pregnant lady? In what way would it be different? If the rash had been there for 4 weeks instead of 3 days, does that make you think differently? So we try and get them to be thinking across scenarios as well. The other issue, which I'm sure you've all got here, which apparently you call Nutella students, is that right? We call them snowflake students, is Generation Z. And I think this we have to really grapple with. It's not going to disappear. That's one thing. It will not disappear. This is a generation of students who are different to us. They're different. You're not going to change them because they are a product of our society at this moment in time. Our parents probably thought the same, and our teachers, when we were students, probably thought we were different. Each generation changes, but this is a generation of students at the moment, and we have to accept it. It's no good as saying, and lament about it. Instead of spending our energy bemoaning it, talking about them, our energy should be in saying, well, this is the situation. What are the characteristics of this generation, and what are the implications for us as educators? Now, we all know they want constant reassurance. And just like you get addicted to heroin, many of these students are addicted to wanting feedback. The only problem is, it's a bit like having a screening test. You hope it's going to be good feedback. So if they get bad feedback, or feedback which is negative, they're going to be worried. And they also want the reassurance. Now, we did some work when I was in Sheffield, where the students said, we don't get enough feedback. And we mapped all the time students potentially were given feedback, and it's vast. But the students don't perceive they're getting feedback. So now, tutors will say, I'm going to give a skill session, I'm going to give some feedback. Sending students the results back. This is the feedback. So we make it explicit they're getting feedback. But also, we specifically tried to train our tutors so that they can actually give feedback which is not positive feedback, just as though they're breaking bad news as a doctor. Because that's what it's about. It is breaking bad news. They have a mental image that they are coping okay. The reality is that their performance is not good enough. So we've started to train the doctors and support our teachers on giving that type of feedback using the same skills of breaking bad news. And that seems to have worked, and it's avoided some of the dramas that other medical schools have described, where students have been given feedback and the students have actually self-harmed themselves. So it is an issue, which then comes into students' mental health and well-being. I'm afraid it's a fact of life that, the students feel that they need to look after themselves. They want adequate time. They want to talk about their feelings. And we have different levels of doing that. Number one, we all recognise that medicine is not going to be an easy way forward. It hasn't been an easy life for me. It's not an easy life for you, and it won't be an easy life for them. So we need to look at ways of looking after ourselves. That is why at the very beginning of the course, we look at them as a person. How do they look after themselves? The importance of nutrition. Of course, the students want to get drunk, but we talk about, the difficulties of that. How to look after themselves, how to make sure they're safe, how to recognise if a colleague is drinking too much, where you can get support from. So we make it very explicit. The other thing that we encourage the students to do is to engage with the wider life of the university. So we're a campus university, so we encourage the students to go to the theatre on the campus. We do dance, to do that. We have a whole range of societies. Now, many of these societies meet on a Wednesday afternoon, so we've made it mandatory that there is no lectures, no teaching on a Wednesday afternoon. We have no teaching at all each week on a Wednesday afternoon. And we expect the students to go and join football clubs. We've got a cheerleading group, baseball, rugby. And we also have a personal tutor system where members of staff, including clinicians, we meet our students either physically or by Zoom, depending on fitting things in. Twice each term, we have contact with the group, with an individual student, and we manage about 6 to 8 students, and we talk about, so how are you getting on in the course? Have you had any difficulties? Are you doing any hobbies? Why not? They might be doing too much hobbies. Are you enjoying yourself? Are you getting on with your friends? Are there any difficulties? The tutors who are on those TBL rounds are designed, that they're aware of if students have got an issue, so that either they will have a word with the student at the end, informally, away from everybody else, or they will contact the student. We also have posters saying, if you need some support, one of the best things is to put them in the toilets. So behind the lavatory doors and in front of the male urinals, we have little signs. Need someone to talk to. We have services provided by the university. Some medical schools, it's provided by the medical school itself, have their own counselling service, but we also, because Edge Hill is the history of it, we have a very good central service. So we do that. Also, students want to be getting involved in, they get bored easily. There seems to be something about boredom. So we try and recognise that. So instead of having an hour's lecture, we've started doing half an hour lecture, but repeat it twice, or what we call a flip classroom. Read something first online and the lecture, or have the lecture and read a bit more about it afterwards. So we've tried to break it up. The students like using technology, so that they seem to have engaged with the use of mobile devices. And in the first 2 years, we loan the students an iPad, so that in the classes, the tutors can say to the students, instead of him drawing it on the board, say, if you want to just search for it, here's a web link, so they get the students do that. So it just breaks it up a bit more, and the students seem to like that, and do things like polling, in the lecture and things like that. And some tutors do, some don't, but we found that through staff development centrally, the students really like that. So the students can use technology. The other thing is about consumerism. They're highly demanding. So that you either respond like a Pavlovian response to everything the students want, or you try and have an adult conversation. I don't think we've got it right, personally, at the moment, and it's more to do with the university rather than our course. The university is very concerned about student feedback and how that affects students coming to the university, and league tables for student satisfaction. The problem is, it becomes ridiculous. The more they want, So our initial vision and what we've tried to do and what we've done in other medical schools is to say to the students, as I said before, we want you to have the best teaching and learning experience. We're not perfect. We know there's difficulties. You come and help and support us to make things better. So, the students getting them to come along. And to try and be adult about it, so that actually we're collaborating. This is a shared endeavour. If a topic is difficult to understand, don't say, I didn't understand it. Say, well, what didn't you understand? What do you think it could have been explained differently? What would you have liked? So we try and get them to be much more adult about it. And in previous institutions, Sheffield and Leeds, it really, really has paid tremendously. I think some of the other challenges is about lifelong learning and flourishing. And part of the ethos of the course was based on what's called Self-Authorship Theory, which I've written about. And the course is more of a course philosophy. And essentially is that we self-author our own lives. We move from seeing knowledge, seeing ourselves, and seeing others in quite dichotomous ways. So what we've tried to do is to help students to recognise that information, can you believe anything you read? Are you sure about that? We say to students, are you sure? And you get the doubt. Well, where are you going to check it up? Where are you going to find that information? And we give them, we start off one of the scenarios, is chocolate good for you or is it bad for you? And we get them to look at just normal websites and compare and contrast two websites. So they're beginning to, that's how we start it off. And then it builds up into evidence-based practice. And can you believe it? And how do you know it's a good trial? You're saying it's a good trial, it's good evidence. How do you know it is? What are you looking for? And we try and get students to then start saying, justify their decisions. So they begin to recognise that, there isn't always an answer, and that actually you've got to look and do a bit more. Identity is important. That, if things aren't going right, is it to do with them, or is it to do with something else? Because one thing we do know is that students have a very high conscientiousness index. They're keen, they do things, so successful students have that. The flip side to it is that they become quite perfectionist. So we try and get them to work through that. And we've been working with some psychologists on that. The other thing is about understanding others, that individuals have strengths and weaknesses, have aspects that you like and dislike. And it's beginning to how we tolerate difference. And a thing called othering, blaming others and, that others are different. But, then, we're not different. We have similarities, and understanding that. And stop labelling, things like labelling patients. We all do it. It becomes subconscious. And it's part of the jargon, and they begin to think that, there's similarities and differences, which then links into interprofessional learning, because a lot of that is about perceptions of others. We also wanted students to have these longitudinal clerkships, which I've talked about, for a longer period of time. And the other one is social accountability. We're keen on that. And that's service learning, which I talked about in the second year, but also I think there's been a big move on sustainability at the moment and climate change, and we've started to introduce that much more, and the university has started issues, and we encourage the students to take part in that. And I think some of the areas which we've got to think about in the curriculum are personalised medicine, genetics, health informatics, research and innovation. How do we introduce that into our curriculum? Because the curriculum is already full, and all this stuff is happening. But it's so what? How can we do it? And I don't think there is an easy answer. One way of doing it, and what we have started to do in the clinical years, is to introduce blocks of time called special study modules, which are 6 weeks, where a student can explore some of these issues in greater detail if they're interested. Because some of the aspects, they're not going to be that, they may not be interested in a certain aspect, whereas others may be. So, for example, research projects, the students do not do traditional research projects. There's reasons to do with ethics. It takes too long to get through ethics. The university at undergraduate level tend not to do many research projects. It tends to be postgraduate. So, but it is important, and what we do, and some students passionately want to be involved with research. So what we've tried to do, is to enable students to have these what we call special study modules, where they can work with clinicians and others in. We don't have huge laboratories. We do have some laboratories to work with existing groups, and that seems to work. It's getting them used to that. Innovation. We started with computing to do hackathons. These things are sort of creative together. I think genetics. We haven't come through that for an SSM, but personalised medicine, genomics is an area. We've tried to introduce these concepts early in the preclinical years. In the clinical years, that we've now got some hospital doctors who are keen on that concept. So they're going to be linking and working with them. So I hope you found it useful and interesting and not too rambling. I don't know what resonates with yourselves. This is our journey. This is what we've grappled with. I'm not saying it's right or wrong, but I think for me, it's about this opportunity that at the top, you need a vision. You need to be able to design the course with a philosophy. What's your philosophy about this course? What type of doctor do I want? How do I want that person to learn on that course? And believe in that and hold on to it. The next level is actually developing the course so that you've got a course, a program which does that, and then you've got to carry people along with you in that process. All of it is a challenge, and I think it's something which, if everybody's involved with, it becomes a shared venture. And it's something which you can get enjoyment out of, rather than it actually being a major trauma to everybody. It's something which, you can see the students growing and developing, and that is what it's about, I think. You begin to see that the students do like that approach that you're doing, so you begin to believe in it. And some of my conviction, most of my conviction, is because that's how I learned. I've seen other students learn that way, and our current students in the new curriculum seem to be thriving in this way. And that's all I can say. You know your context. It will be different to mine, but if there's anything which I've talked about which resonates, and you think, I think we'll have a go with that, I wish you well. Because there's nothing better than having really keen students who are interested, passionate about doing medicine, because one day they will be your doctors and my doctors of the future and societies, and you want them to be able to thrive and to flourish and to be clinically competent and to be members of society. So it's quite a vision, really. Thank you.
Thank you for our excellent lecture, Professor Sanders. And before I open for questions, I would like to make a parallel with our course. You have a 5-year course, we have a 6-year course, and we think that it's not enough. How do you deal with this? And how many students do you have per year in your medicals?
I'm quite truthful about our course. At the moment, we have 30 students in a year. And 30. But that was deliberate because the university has never, ever had medical students before. Never. And we've had to alter systems in the university. Our staff, we've had to bring them in. Each year, we've had to develop the curriculum for the next year. We just haven't got that. So we're a small year, and we fully accept that. And that's probably why we've been able to get the students more adequately involved. But having said that, Sheffield has 250 students in a year. Leeds has got similar numbers. So, it can be done. We've got a small number of staff, don't you see? Teaching anatomy, we've only got one anatomist. So if we have to have the radiologists teach, our biochemists, we've only got one. But we've got colleagues in the other university departments who are happy to come over. But we've also had some of the hospital consultants, like the clinical biochemists, coming in as well. And we've had that group because it's a new area. The local hospitals want to be involved. So that's we're small. So that's one thing.
If you're not small, maybe the rest is too big.
Well, maybe too big. Now the other thing is that if you think 5 years may not be long enough, in the UK at the moment there are 4-year courses being started. If you've got a degree already, our students come straight from school, average age 19.2 years. If you've got a degree before in biomedical sciences, you now can do medicine in 4 years in the UK. 4 years. Because they do 1 year preclinical and then they go straight into the clinical. And you've got to remember that the final year on our course, there's very little teaching as teaching. It's shadowing doctors. So it's intensive, the students. And it comes to this dilemma of what do we teach and the depth we teach it at. And it is a real issue. But you have to remember that the UK context, when you get your degree, you do not get full registration to be a doctor. You can't be an independent doctor at the date when you get your degree. So you go up, get given the degree, and there's no job for them. You can't do anything. You can do another job, but you can't do medicine. You cannot, because you're not registered. You then have to work for 2 years in hospital jobs. We call them foundation years. And then at the end of that, you then become fully registered. And during those 2 years, they've altered it. It used to be 1 year, 6 months medicine, 6 months surgery. Now it's 2 years, and you do. It varies slightly, depends on the area, but normally you do 4 months medicine, 4 months surgery, 4 months A&E, 4 months general practice, and then there's usually a mixture of, you can do psychiatry, ear, nose and throat, paediatrics. During all of those attachments, for half a day a week, there is teaching. So the doctors will get time out where they're not being taught anything. They're also supervised in their work much more. They are independent. They're working as doctors, but they have what's called an educational supervisor and a clinical supervisor. So the educational supervisor is sort of responsible for each doctor for those 2 years to make sure they're progressing, and they have work-based assessments. The clinical supervisors are those that take a responsibility for teaching. So actually, they are having a 7-year course.
But how do you, after these 2 years, how do you evaluate the learning of these physicians?
At what level, sorry?
Yes.
Sorry?
The foundation years, right?
Yes, the foundation.
For the foundation.
For the foundation years, how are they assessed? Work-based assessments only. Only work-based assessments, and professional behaviour. Because technically, if they don't turn up for work and things like that, they won't get doing unprofessional things. But they have to be signed that they're professional, that professionally they have appropriate behaviours and attitude. Well, behaviours. behaviours, because you can't measure their attitudes really, professional behaviours. These are judgments, but they do, the typical one, I can't remember how many they do because it varies, it keeps changing, and I'm not directly involved with the foundation year, but they were doing so many, they have like a logbook, so they have to say management of acute illnesses if you're doing medicine. So there are certain conditions which they then are expected to have covered. And that's what the clinical supervisors sign them off for. Does that kind of make sense?
Thank you for your lecture. And, I think the most distressful thing about reforming the curriculum is that if you really give the students the rich opportunity that you're giving your students, definitely you won't have time for covering all the subject that you have. For example, in endocrinology, if you have a 4-week endocrinology course or 8-week, you go through diabetes, but you won't go through thyroid problems or adrenal problems and hypophysis problems. And we've been through the medical course that we needed to learn everything. We had to go through all the glands and know all the functions of all the glands and all the hormones. And if you give this type of experience to your students, you definitely cannot go through everything. Yeah. So how do you work with the distress of your teachers and knowing that they won't be able to teach everything they want to teach?
Right. The General Medical Council have a list of what they expect to be covered in its broadest sense. I think it comes down to the depth of it, really. For thyroid, students would be expected to know the anatomy of it. They'd need to know the functional aspects related to the histology. All the development, of, I can't remember it, so, the basic stuff, but the thyroglobulin and, how it comes, the iodine and all that, they don't learn it at any great depth at all. They don't learn what we'd regard as quite detailed information, because it's not felt to be appropriate for them. If they decide to do endocrinology, they need to know that, and they will learn it in greater detail. So it's learning sufficient to enable them for the role as being a foundation doctor. So they've got sufficient understanding to know why the pathology might be happening, how the drugs work, and why and the effects of the drugs. So that we're working at that level. It's like the anatomy. If you're going to do surgery, you obviously need to know it absolutely backwards. They don't need to know it. They need to know certain things, like, the cranial nerves, but they don't need to know all the detailed anatomy that you and I learned, every sort of basal foramen and everything. It's irrelevant to them. They're not going to be head and neck surgeon. If they're going to become a head and neck surgeon, my daughter is a speech and language therapist. When she did speech and language therapy, she needed to know everything, incredibly detailed, far, far more than the medical student, same as a head and neck surgeon. Because in the UK, speech and language therapists do assessments of dysphagia and voice and the sort of palatal movement. So they need to understand that. But our students don't need to understand it. They need to know that there are holes in the base of the brain and base of the skull, and that's what they are, and nerves come through it, and these are the nerves. But they don't need to know, the detailed anatomical relationships, like peritoneal reflection. I have about the peritoneum and all this stuff we learn. We need to know that if somebody gets stabbed, what's it going to hit? If at the end of the X-ray, what's that shadow there? They need to know it at that level. They need to know where the artery is. They need to know the name of it. But they don't need to know all the detailed information. Of course, if they're going to be a surgeon, they need to know that. It's the same as the pharmacology. They need to understand that there is a drug, how this drug works. But part of it is expected that during... that's what we teach. But they're also told that you still need to keep reading about it. So if they are interested, they can go to a big textbook or look it up on the internet. It's the same as cancer, all the detailed stuff. 40 different types of leukemia. They don't need to know all those variations, so we don't teach them it. They need to understand the core principles. Like looking at histology, a blood film. They need to know this is what a normal blood film looks like, but they're never going to be doing it. As a medical student, they don't do, there's no, our medical students are not going to be taking a blood film, staining it, and looking at it under a microscope. So they don't do it. We don't train them for that. They need to in our context, if they're going to train to be a haematologist, sure, they have to know, but then they learn again. So to be a haematologist, in the UK, it might be 8 years specialist training. And it starts off, but theoretically, they're building on what is a good foundation. I mean, people always lament that they never know enough, but actually, every generation's always done that. Surgeons who, 50 years ago would be lamenting that the medical students still didn't know anything, even though they were learning it from Gray's Anatomy and they were doing dissection. I think it's, we have to be realistic. They need to be able to do it. It's like the level of interpretation of X-rays. They need to know, is this normal or abnormal? If it's not normal, about seeking then, can they manage it or not manage it? And I had very simple views for training medical students when they used to come in when I was a primary care doctor. Is the patient well? That's number one. Or are they unwell? If they're unwell, can I manage it in general practice? Yes or no? If I can't manage it, they get referred. If I can manage it, I need to be absolutely sure what the diagnosis is and its management. And it's far better to be referring it than managing it where actually you're not sure. And you've got to be aware of what the key things are, meningitis, sepsis, those types of things. So picking up dehydration. So we'd rather our students can develop that rather than knowing all the minutiae. Does that sort of answer it? It is a dilemma, and I don't think there is an easy answer, but a lot of this comes with further training over the years as well, in the house jobs, these foundation years. So they're beginning to build it up. Yeah.
Thank you for your lecture. It was very great. So, I should introduce myself before. I'm semi-native. I'm third-year medical student in Tunisia, in North Africa. So I believe that this system, this curriculum, is very great. But you say you have 30 people each year.
On our course at the moment.
On your course.
Yeah.
Okay. I believe that's great for that number, but in our university we have 250 people each year.
Mm-hmm.
So how can you manage? Is it a great idea to apply it on a big number?
Mm.
And how can we manage that?
Yeah.
And my second question is, you said you don't have to get into the details of everything in the 5-year course. How can you decide the line between the fundamentals and the advanced thing? And when will you be learning the advanced thing?
Yeah.
Is it at the residency or?
Yeah, residency level. So we'll start with the residency. The agreement is is what I call a gobsat. Good old boys sat around a table. So basically, it's experts, doctors who sit around developing the national curriculum, what they consider should be important or not. And that's the General Medical Council. And it then is sent round to the medical schools, and they're constantly refining it. So they then take into account, like a Delphi exercise, what should be included and not included. And there are national, so that's the broad General Medical Council. Then we have, like you do, special colleges, say for the surgeons, palliative care, paediatrics. They have got what they call the core undergraduate curriculum. So they do it between their own members, what they think is important as well, and that comes round to medical schools. So they decide that's the content. So that's, I think, reassuring, because then that dovetails into the core postgraduate. Now, the GMC doesn't dictate it for the postgraduate, because its role is the regulation of undergraduate training predominantly and overall standards. But so all those colleges, like the surgeons, will have levels for undergraduate and postgraduate. So they are aligned. And they also have higher specialist training. So if you want to be a specialist surgeon or a specialist paediatrician, like nephrologist, because if you're a paediatrician in the UK, they only expect you to be at a certain level, even if you're a consultant paediatrician. If you're a general paediatrician, if you then are further trained, you are expected to have another level of skills and knowledge, and you take another exam. So it is progressive like that, and it's very closely aligned. It is. So I think we can be reasonably reassured that the level of knowledge and skills is fit for purpose. What we don't do in the UK, and I don't know what happens in Brazil, I've certainly seen it in China, is that, and India, students are given information which is totally irrelevant to their role as being a doctor. The level of biochemistry is sort of nature level. It's actually totally irrelevant. They're never going to use it. So why fill your head up with it? So I think of course you need to understand it, but you're not a pharmacologist. So you don't need to know all the massive amounts. You need to understand the basic principles of how a drug works and how you're not going to be researching it. So our students are not doing pharmacological research at that level. Some students in some medical schools can do an extra year in their training and do pharmacology at that level. Our medical school doesn't, and the newer medical schools in the UK don't. So that's one thing. The argument, what you've just said, I can fully appreciate. What I can say is that both Leeds and Sheffield and Manchester have a very similar system in the first 2 years. Very similar. In Leeds, we had something like 250 in the year, and we had groups of 12 doing the equivalent of the TBL. Wasn't the same, because in Leeds it was only there's only one session each week in year 1 and year 2. So it's slightly different, but they were run. Some were run by doctors, some were run by nurses, some were run by people who had been doctors and nurses and retired, because they were quite keen to keep on working. And and it was all on one day. Some of the lectures would still be 250 students in a lecture theatre. Some of them, there was more self-directed time. I think that's one of the difficulties that's happened with Edge Hill. There's several reasons why we haven't done a huge amount of self-directed learning. But one of them is that by having a small group, it's easier to teach them, if you see what I mean. When you've got large numbers, you can help students and split it up and make it much more flipped. The flipped classroom is either you read something before you're seen, before you do a session, or after, which means that instead of running a session for 250 students, you only run it for 120 students. Okay, so instead of running it for an hour, you run it twice for half an hour, and some students would read it beforehand, and some students would read it afterwards. But there would be time when they can do it independently. But also, it's the course management, because obviously it's impossible. Say they do dissection still. It's impossible to have 250 students in a dissection room. So you'll be mixing it up much more what they do, like communication skills. Not everybody's good. They might have a lecture for 250, but while some students are having a small group, it might be that only a quarter of the year, at one moment in time, is learning on a day communication skills, but another group is doing something else. It's just the organisational. But this sort of envelope of having a smaller group for discussing what they're learning as an individual, talking about the course, talking about their professional stuff, helping where they are on objectives, they do it. And this idea of doing regular quizzes and things, they do it. They have an online system, and they have an online sort of tracking portfolio. So everything goes into it. So you can do it. It's just the organisational aspect. The biggest issue is this having these regular small groups. How do you actually do it? And the funding. That is the real issue. And having the space at the same time. Fortunately, both Sheffield and Nottingham, Sheffield and Leeds, but places like Nottingham and Manchester have it. In the medical school, they have sort of a floor of the medical school, which are small meeting, sort of group rooms. So you need the space, that's number one, and you need the people to teach. So you have to spend the money on that. But as I say, during those foundation years, you can actually do a project. We have a system that in the foundation year, if you can have what's called the academic foundation program. So if you are in the top group of students, you can engage with what's called the academic foundation program, which means that the jobs that you are doing are linked more to academic university type departments. Does that kind of make sense? Because you're going to be the future consultants, and you're on a track. Now during that during those 2 years, one of those one of those aspects, you become an academic clinical fellow, and they do, instead of doing 4 months of one of the clinical subjects. So say you're going to be an academic clinical fellow, say you're on an academic program, and you're sure you want to do surgery. Why are you doing it in maybe 4 months? They all have to do general practice, but why are you doing 4 months in paediatrics? Do you see what I mean? So the argument is that you could do something else. So they have the opportunity to teach in those 4 months, so they can teach for 4 months. So some of those doctors act as tutors for those small groups. Some of them, as I said, are retired doctors. Some of them to keep doctors interested. One of the problems with senior staff and consultants is job enrichment. They get bored doing the same job time and time again. So they either go into administration or doing research or doing private work in England or doing teaching. So consultants in the UK have what's called they have units of professional activity which are 4 hours. So a week has sort of 10 sessions of 4 hours. So for example, if you're a surgeon, you might do 2 sessions operating, 4 sessions outpatients, 1 session teaching, because you've got responsibility for postgraduates. You might be able to negotiate 1 session for undergraduate teaching as well. And then if you want to do private work, you can negotiate sessions for that, but then you don't get paid by the National Health Service. And some consultants are happy to do that, so they take a pay cut from the National Health Service, but they make that money by doing private. And it's all about making sure that the consultants are feeling refreshed and it's enjoyable for them. So that it's all negotiated, that contract with the hospital it is. So teaching hospitals tend to negotiate it so that they're allowed some extra teaching. Also, it's felt that junior doctors, there's a similar scheme for the junior doctors. So some of these, in a big medical school, because how many 12s go into 240, whatever it is, 20. So you need 20 groups running. So you've got to get 20 rooms, 20 tutors. So where are you going to get them from? And they are expensive, but some of them you can get free, some of you having to pay for. Some of the GPs who are retired love doing it, and they don't charge anything. Other people want to get paid. So, it's about negotiating. But, you just get volunteers. Does that answer it? No, I don't know how you would do it here.
Thank you very much, Dr. Sanders, for sharing with us your rich experience. As you said, we are preparing doctors for the future, and it's fully acknowledged that mental health needs are growing. So I would like to ask you to comment on your approach on teaching mental health issues and psychiatry from preclinical to clinical.
Yeah.
Could you comment on that, please?
Yeah. At undergraduate level, the first year start looking at psychology, normal psychology, because most people would not have done psychology. So it begins with that. Some of the issues, as you and I know, are related to psychosocial factors. So it's an understanding of that and how it impacts. During their attachments to primary care, that they will obviously see patients, and that starts linking into much more about these aspects related to the pathology. So if there are pathology, because some of the aspects in mental health, there are physical issues, obviously, so changes related to alcohol, changes related to drugs, delirium, those sort of aspects are still psychiatry. As psychiatry as an attachment and its widest mental health is looked at in the clinical years. So just like they have an attachment for 4 months surgery, they will have 4 months psychiatry attachment. Now, it depends what we mean by psychiatry, because when I was a student, psychiatry was going to a hospital which was basically locked up with patients with severe mental illness. That, it's not any longer. We have a large, in the UK, the normal hospital, the hospitals that we have are right. I'm trying to explain it. The care of patients in the community with mental health, some is by general practitioners, family physicians. So during their attachment as a family physician, they will do that. There are services which doctors do not provide, community health trusts. Some of that students will experience in year 2 with community organisations, because there's a big move at the moment with what we call social prescribing. So therapeutic gardening is an aspect where people with mental health loss may do garden, grow flowers and things, and there's schemes like that, and students, and they talk about that experience. So that's another area. 90% of mental health, I don't know about Brazil, is in the community. So the psychiatry attachment that we've arranged for our students, and they haven't done it yet, because this is this year, we've got arrangements that students have got like an experience of seeing mental health being managed, where they can clerk patients, they can see them. The severe mental illness management, they're not. We've decided we're not exposing the students to, patients with long-term major psychoses who are managed because they're not going to be managing that. Only psychiatrists will be managing it. So it's predominantly what they would be recognising mental health, how to prevent it in the community and manage it in the community, but also understanding the severity of it. So some of the aspects of mental health we're not exposing the students to, because like therapeutic communities and things like that, it just becomes impossible. For child and adolescent mental health, it's more about seeing it in action rather than dealing with it. However, during the foundation years, there are psychiatry, 4-month psychiatry training. And it's felt to be postgraduate, but in the UK, a lot of the management of mental health is not by doctors, it's by nursing as well. Edge Hill has a very good mental health nursing unit and training. We've tried to get them involved as well, to be talking about how they manage it as well. So not all the time is going in the 4th year is out in the community. They have blocks with us on site for 4 weeks, and then they go out on these rotations.
What about mental general hospital units? What do you think about? Should students be exposed to inpatients in general hospital units?
With psychiatry?
Yeah.
We haven't done.
Right.
We're not planning to do that, because we probably could do it with a small number. For medical schools with large numbers, it becomes really difficult, mainly because the number of patients in hospital units for psychiatry is actually small. And there are issues related to security, because some of them are locked wards, closed wards. So that is an issue. Management of acute delirium and acute psychiatric emergencies, they will see that often during an attachment related to accident and emergency, overdoses and things like that. It may be some of this is contextual. I don't know enough about Brazilian system. Management of dementia is predominantly GP, but then they would be seeing how, if they were attached during the general practice attachment, they would be seeing patients with dementia, but also the role of the nursing team, which is predominantly nursing team doing that. But actual long-stay patients with dementia, they wouldn't be seeing But because they wouldn't be looking after them, they're looked after by postgraduate doctors who are doing psychiatry. Does that kind of make sense?
Thanks for your thoughts.
And knowing all the ins and outs of the, some of the treatments or psychotherapy, we're not training them. They're going to be trained in basic counselling skills, but not in, psychotherapy or anything like that. Or child and adolescent, say, family therapy. We're not training them in family therapy.
Thanks again for your nice presentation. And I have a specific question regarding emergency medicine. And in the assessment day that the studies do every year, the last one they had, one of their main concerns was about how to learn some procedures. For example, orotracheal intubation and central venous line, and this kind of procedures that, because like we talked before, one of their main fields of work when they finish their graduation is in the emergency rooms all across the country. So how do you think we should teach those procedures? Because they rely on our rotation to learn, but our patients are actually maybe the most difficult to teach them because they are very severely ill. So what do you think about that? Thank you.
I think this is where simulation goes in, the role of simulation. The General Medical Council, if you look at the UK context for a start, the General Medical Council only expects students to be able to manage a relatively small number of procedures, believe it or not, clinically. By the time up to the point where they go to foundation year, they're expected to be able to take blood, do a blood gas, venipuncture, do a blood gas, insert a venous cannula. I don't think that, I'd have to look at the latest version. I'm pretty sure that they don't have to put in a subclavian line. They need to be able to maintain an airway, but endotracheal intubation, I don't think is actually a requirement to qualify. So those would be taught and assessed usually in medical students, but in simulation. They may have the opportunity to do it on clinical placements, particularly in the final year. But during their foundation year, they would be taught those procedures, both in simulation, because the hospitals have simulation centres as well, and with real patients. But then you're immediately doing that, you're straight into that. So they're felt to be postgraduate. So if you're saying how best to teach it, the best thing, I think, is to learn it in simulation. And I think many people recommend learning this. So it's a bit like going skiing. If any of you have gone skiing, you have to get used to wearing the boots and the skis. It feels different. And it's pointless going into really good snow until you can do that. And you're wasting time, and it's very frustrating. It's far better to go onto an artificial slope, get used to doing it, get used to doing the basic procedure, and then go onto the real slope. It might feel slightly different, but at least you've developed that almost that motor memory, so it just feels right. And I think that's the same with simulation. Our students are expected to be able to suture, but the opportunity to suture a real patient are actually quite low, believe it or not, because first of all, if they've done the simulation of suturing, in their final year, we haven't got our students to that point, but But in other medical schools, they would have done the simulation and they're assessed on that in simulation that they're competent. If they've done the simulation, they can then do it under supervision during their attachment, because they do A&E attachments. But I think it's something to do with the level of responsibility. The time where they are really learning it is during the foundation year, because they're doing lots of them then. But I think simulation, for me, is key. It is a really, really important way. I learned to do stuff straight on patients. In retrospect, it's a pretty, I learned to do cardiac catheters, shown one and did the next one, and then it was my list during a cardiology job. That was the old, same as lumbar punctures, that was the old days. It's fraught with problems, and you're not quite sure what you're doing. It's scary. You've got to be scared. You've got to have that degree. It's always going to be scary for the first time, but I think if you feel that you've got the control and you understand it, you've got that level of confidence to do that. Does that answer, Diego?
Sure, and just to a complementary question, when should it be taught during simulation? Because a problem that I think is if you teach it on the end of the graduation, maybe they won't be able to practice enough. So, but otherwise, if you teach it in the beginning of the course, they will probably don't get many situations where they can put this knowledge on practice.
Well,
so what do you think? Do you think it should be taught repeatedly, or move on to patients without disease and then patients who are ill? What do you think?
Right. Well, we've tried to phase it for what they are at. We've tried to phase when when it's going to be done. So in year one, simulation, want to better things like urine testing, simple stuff. Being able to do a peak flow meter because it's part of it. That's appropriate. So they've learnt to do that, and they're assessed on that in year one. Year two, I can't remember what we've included in year two now. Year three, before they're going out into the medicine ward, it will be venipuncture. So they're taught venipuncture so that when they are on the ward, they can do venipuncture. They might be taught to do a venous line. So there might be the opportunity in year three, which you'd expect them to do, if possible, to do that. Lumbar puncture, we wouldn't teach it at that stage. We wouldn't teach it, or the plan would, for us, is that we would, that would be something for the final year. Because in the final year, they although it's a year of shadowing, and they do come into base. So they do come back to the medical school. So, they do 4 months medicine, 3 months medicine, and then they are back for 2 weeks. So in that 2 weeks is almost like a review of what to learn, what to expect. Because most medical schools actually do the knowledge-based exam at the end of the year before the final year. Now that's changing because there's going to be a national knowledge exam. But that's going to be at the very beginning of the final year for students, at the very beginning, because the idea is that the final year is a time for skills-based learning, predominantly. So that's the time when we plan to do things like more complex scenarios linked to. We do life support during the cardiovascular in year 2. We do some basic. When I was in Leeds, all the students in the first year did basic first aid course. In the UK, there are standard um, training courses for first aid. So, you know, how to manage a collapse, how to do that. And it's mandatory that in an organisation, say, if you're working in a factory, that certain people are first aid trained. So they have to do a course. And we did that. We stopped it because they started to charge too much money. But the students used to love it. And I think that's I think it's useful. Because if you're a medical student, you know, somebody collapses in the street, like we were in the park, you know, people say, is there a, you know, as a medical student, you feel as though you want to be useful. So, you know, some of the students set themselves up into doing their own first aid training courses. Senior students teach the younger ones. Does that happen here, where senior students teach earlier students doing things?
I studied in Tunisia, and we have it in the first year.
Yeah. Yeah.
First aid training.
Yeah.
And we are taught by students, peer-to-peer.
Yeah, peer-to-peer, yeah. But I think things like first aid training is really quite useful.
Yeah, everyone knows about it.
Yeah. Yeah, sure.
Good morning. Thanks
Hello.
for a brilliant lecture and for sharing your opinions with us. I was really impressed with your observation on our Generation Z. And apparently, one of the things that happens is that in a school like ours, most of the course of the medicine is given by specialists. And so we try to teach them everything that we know, and there's a lot of information going on.
Yeah.
And the Z generation is really focused. You can see our TI people from informatics, they learn what they need to do at that moment and nothing else. And so one of the ways to try to get around this, in my opinion, would be if we could have a foundation course, but something like from the 4th year on, the curriculum will be an open curriculum. Like the student could choose where he wants to go. It's very frustrating, I think, from the psychiatrist to try to teach mental health to a student that has already decided he's going to do surgery, is not interested on that, and it's very frustrating for a pediatric surgeon to try to teach someone who's going to do public health, is not interested in what was it. So how could we tailor a curricula that we have a foundation, but then like in a tutored way, let the student from a certain point on choose what he wants to learn and begin his career?
Yeah. I think the simplest and easiest way is that even if you're going to be this is an anecdote, but I think it's really interesting, important. When I was a student, there was somebody else. There was another student in the year above me, who made it very clear to everybody that he wanted to be a forensic psychiatrist. He said, "I want to be a forensic psychiatrist," and he told everybody that. Everybody he met. And when he got to his final exam, I was doing my the professor of surgery I did my job with in surgery for 6 months, and he told me the tale of this man. And in his final exam, he had to examine a patient with a hernia, and he came in, and he's quite we call it cocky, and he said, "Well, I want to be a forensic psychiatrist." Okay. I don't think I'd be dealing with that. And the professor of surgery, Bert Duffy, said to him, he said, "Right, this patient thinks he's Napoleon and he's just killed somebody, but he's actually got a hernia and he's complaining of pain in it. It's your job, because if you don't diagnose it, he's going to die. Okay, so I want you to examine him." So what he did was basically you still needed to know how to tell whether it was, the type of hernia. I think it's about deciding what is essential for all the doctors to know.
Okay, great. That's a core.
Once they've done that, and the level, if you can do a curriculum, and it's usually slimming down the content, as you've just said absolutely rightly, what it allows you to do in the curriculum is to compress it. So instead of having 10 weeks, say, psychiatry, you only do 6 weeks psychiatry, but you only learn what is absolutely essential. And I don't know if your professional college, but the core undergraduate curriculum for the Royal College of Psychiatrists will have undergraduate students should be able to identify and manage There's only about something like 10 things. It's absolutely essential because and it doesn't matter whether you're a surgeon, it doesn't matter what you do, you need to know that because you may be faced with it. That identification of delirium, being able to manage an acute delirium, or something like that. Which then, if you've got a reduced amount, you've still got the whole of the time, which then allows you to do several really exciting things. We haven't done it with our course yet, and it's because the numbers are a bit small, and it starts to just the logistics. But there are a couple of opportunities. One is to allow students at the end of year 3 to leave the course for a year and pursue an area of particular interest. So that is possible. And if you've got a very small year, it's very disruptive because they then have to come back into the year again, and it disrupts we haven't got enough students. But if you've got larger numbers of students, it's quite easy for a student to take a year out. So then you can specialise. They can get an extra degree, so they can get a bachelor's degree in another topic. So some universities offer radiology, some of them offer basic sciences, some of them offer what they call clinical sciences, so it can be anything. If they want to do haematology, they can go and do haematology. They're assessed, so there might be a research project, it might be more clinically orientated, so they can do that. The other thing they can do is to have special study modules. Now, a special study module in most medical schools is 3 months. So up to 3 months. It's usually 6 weeks. So they can make a choice of doing something that they really want to do. If somebody's really, really got that passion, say you want to do, say you wanted to be a psychiatrist, what you could do is at the end of year 2, you then do a BSc, a Bachelor of Science in Psychology. So they allow our students to do that, to go, and they go to some of the psychology lectures, and they do some psychology project. They have to work really hard. The medical school will usually only allow it if you're a very good medical student, but students do it, and they actually get a bachelor in a BSc in psychology. Then the next time they do it, they at the end of their it's the 3rd year of the course, but the student's 4th year, they can do they can do a special study module in it. Then the students can do what we call an elective, so they might decide to go abroad. For my elective, I didn't go abroad. I stayed in England, and I actually did obstetrics for 3 months. And I went and sat in with the. I was fortunate because the time when I did it, there was a new group of midwives starting, so I actually learnt all the babies coming out of of the womb and everything. So I bought the midwifery book rather than the obstetrics book. So I learnt midwifery. So when was a GP, I actually did GP obstetrics. I used to deliver babies and put forceps on and ARMs and start them off in labour and put the syntocin on them. And I felt really confident in that. And we had 3 other partners that did that. So I did a lot of GP obstetrics because I found that interesting. I found it fascinating. But I did that as an elective. And if you really do want to do research and you're doing medicine, there are opportunities to develop to do your PhD. Now, I know you do it here, and it's quite difficult because you end up doing it for 10 years. But there are alternative models. So in Leeds, their model was that at the end of your first year, you have, 3 months holiday as a student? At the end of then? So what you did in those 3 months was you could do the beginning of your research. So you're beginning to work with a group of getting your research question, starting your literature review. At the end of the second year, the same. At the end of the third year, you take a year out. Then at the end of each of the years, for the holidays, that gives you that opportunity. So the students do not get their university grant for their holiday. Okay?
Okay.
So we had another scholarship system, and this was a TV celebrity called Jimmy Savile. You might have heard of him. It was all about sexual abuse. But that wasn't known at the time when when the university accepted it.
Of course. Definitely.
So it was the Jimmy Savile scholarships. Anyhow, but we didn't know that. And fortunately, there was no scandal for us when I was in Leeds. But because he lived in Leeds, but he sponsored 2 students each year so that they could get their student maintenance and grant so they could do their PhD. And they were called law scholars. You can do it, but it's partly the university regulations get in the way. You need a student who's incredibly good in learning medicine but is also capable of doing a PhD. And you also need to have, it's usually the holiday, because I don't know about here what students do, but if you've got very rich parents, you normally take 3 months holiday. If you haven't got very rich parents, you work to get money. And, it's difficult for some of our students to manage. And increasingly in the UK, we're getting more mature students who actually have a family to manage as well. And people change careers doing medicine, they're 40 or something. And it becomes difficult. So these are our alternative systems. But I think you can do it. And I totally agree with you.
I believe the word is flexibility.
Yeah.
We need, in the name of the next generation, to be more flexible.
Yeah.
On what we let them tell us what they want to teach them, and not just you have to know this.
I think it's the same like having children, though. There's things which they might not want to learn it, but they're going to have to learn it. They're going to have to learn it because whatever job you do. But that comes down to, I think, explaining why it's useful. That actually, even if you are going to be a psychiatrist, when I was in Sheffield, it's got a World Centre for Public Health called SHAR. And a student on the feedback, anonymous, said he thought it was completely waste of time learning about public health because he wanted to be a surgeon. Complete waste of time learning public health. I wanted to be a surgeon. We should have spent more time doing surgery. Yeah, but the problem is, as a surgeon, I know surgeons that engage with public health because there are public health issues. He's got a very narrow view. And I think one of the difficulties is that a lot of students say, well, psychiatry is a complete waste of time, But actually, the reality is that even if you're going to be a surgeon, patients get acutely ill, mental. You might have to operate on patients with mental illness. You know, it's a very narrow view, and the trouble is they have a romanticised view often of what these jobs are. And one of the areas we've just started at Edge Hill, and one of my colleagues leads it, it's Jeremy Brown. We've started almost like mentoring and coaching that we've identified consultants who have got particular areas, and if a student, we call them career champions. So if a student has got a particular interest, they can make contact with one of these people early on. And we've had a couple of students who want to do cardiology, and somebody else wants to do surgery, and they've met these consultants, and at the end of the day, you know, when the medical school finishes, they've gone to say an operating session, or they've on a Saturday morning they've gone into the hospital. So they begin to see that that's what the job is. Because until you start doing the job, you've got a romantic. You think, you know, a surgery is just going to be the cutting. But you know, I remember a surgeon telling me I didn't feel particularly, you know, I didn't feel that I was particularly good manually, you know, even though I used to do obstetrics and stuff. He said, well, why don't you do surgery? I said, well, I don't feel that confident, you know, doing the manual stuff. He said, oh, you don't need to worry. He said, 90% of surgery is selection and post-operative management. Now, it might be right, but, you know, we have this thing called cack-handedness. It's where, you know, basically you can't coordinate. I mean, you're going to run into problems. You can tell a good surgeon, and a lot of surgeons do things like carpentry or making jewellery. There is something about the dexterity and like doing it, but actually it's not all the job that they do. And also, you know, you've got teamwork and all these issues. And I think, you know, until you begin to see what the job does, it's very difficult for students to be saying, you know, this is what I don't want. And I agree that they need to have choice, but they need to also be pretty general, and that's what we did.
There has to be a mentorship, a tutorship together with that.
Yeah.
It's 11:30 already, so we would like to finish the session, official session, so people can go to other activities at the university. But Dr. Sanders, we really thank you for this presentation. I think it enlightened a lot of, for us, for our curriculum thinking. And I think we can informally stay here and exchange questions. But officially, we're finishing the session at 11:30. Okay, thank you very much.